Hello and welcome. Today I present to you a case regarding complex malabsorption and nutritional management. So we have a case regarding a 32-year female archaeologist presenting with severe malnutrition, multiple GI resection, and complex nutritional requirements. So we see here her initial symptoms, which began 3 months ago, included abdomen distension, weight loss about 12%, so 16 pounds of normal weight, nausea, epigastric pain. Then on admission, when she was presented to the doctor's office with fever, rash, cough, malaise, diarrhea, and respiratory distress. Her relevant prior medical history included Crohn's disease and a prior terminal ileal resection of 79 centimeters. So her Crohn's disease led to the resection of the terminal ileum, which increases the risk of bile acid malabsorption and vitamin B12 deficiency. Apart from that, she has chronic diarrhea and vitamin deficiencies, including vitamin D and B12, which affect the nutritional digestion and absorption. Along with that, she follows a strict vegan diet. So she has risk of short bowel syndrome, which is from the combined prior and, as we will see, other small bowel resection that reduces the functional bowel length, heightening the risk of this condition. Her labs were taken and found albumin levels to be 1.8, which indicates severe inflammation, malnutrition, low levels of vitamin D and B12, low levels of hemoglobin, 10.9, which indicates anemia, likely due to the iron and B12 deficiency, as well as she has elevated levels of bun and creatinine, which suggests dehydration and being in a catabolic stress. Also, it was noted that she had elevated white blood cells, indicating infection that also requires increased metabolic demands. So based on her symptoms and labs, she was diagnosed with hantavirus pulmonary syndrome, coccidioidomyosis, the valley fever, and small bowel obstruction due to scoliosis. Upon exploratory laparotomy, it revealed that she had a necrotic jejunum. She had a necrotic duodenum, which promoted surgical removal of the necrotic tissue, about 100 centimeters of the jejunum and 22 centimeters of the duodenum. Also, it was noted there were bezoars, which is the irregular masses found in her bowels, and an end-to-end anastomosis was performed. Now the symptoms involved, because of the resections, you would have decreased absorption of iron, calcium, magnesium. You would have also decreased absorption of the fat soluble vitamins like the A, D, E, and K. And you would have severe malabsorption syndrome affecting the GI system. For her neurohematological system, based on her labs, she has high levels of white blood cells indicating infection and inflammation. CRP, which also indicates infection. She also presented with DIC and increased risk of bleeding. For her renal system, based on her labs, she had high levels of bun and creatinine, indicating renal impairment, and all these symptoms and its effect on nutritional absorption means that you have malabsorption, reduced reabsorption of vitamins, minerals, and all the other nutrients. And because of the loss of the terminal ileum, it causes the bile acid and vitamin B12 malabsorption, causing fat malabsorption and chronic diarrhea. Other systems involved include the integumentary, hematological, and renal systems that lead to impaired wound healing, anemia, and electrolyte imbalances. She was suggested to go on a enteral feeding PEG placement due to the oral intake insufficiency in the short bowel syndrome. So the plan was step 1 to get the estimated needs. So based on her weight of 53.6 kg, she requires 1600 to 1900 kilocalories per day, 80 to 107 grams per day of protein, and about 1600 milliliters per day of fluids. The formula selected was the Vital 1.5 kilocalorie milliliter, which is the hydrolyzed protein plus the MCT fats for malabsorption. Step 3 would be the enteral prescription, so given the Vital 1.5 kilocalorie per milliliter, so 50 milliliter per hour for 24 hours, giving 1200 milliliter of fluids, 1800 kilocalories, and 81 grams of protein, which satisfies her nutrition needs. And then step 5 would be to monitor the parameters like the electrolytes, renal, stool output, the weight trends, based on giving her this PEG placement. Why choose the Vital? Because the peptide-based protein is hydrolyzed whey protein, 70% MCT for fat absorption, and is pre-digested nutrients, and is also better tolerated based on her GI symptoms. The other formulas we can look at: Javity, which is a high fiber polymer. It contains 1.5 grams fiber per 100 milliliter. Is harder to digest and absorb in malabsorption short bowel syndrome, and is not recommended for short bowel syndrome. Another formula includes the Juven, which is a supplement only, so it's not a complete formula. Another one is Promote, which is a polymer intact protein. With intact proteins is less ideal when the brush border enzyme bile acids are limited in the short bowel syndrome. So the recommended formula was the Vital, which is a semi-elemental formula, peptide-based protein. Now the nutritional implication and long-term management. So since her duodenum and jejunum was removed, she has decreased iron absorption, decreased calcium absorption, fat digestion, and vitamin absorption, leading to anemia risk, bone loss risk, steatorrhea, and low levels of vitamins A, D, E, K. And based on her ileum resection, decreased vitamin B12 absorption, which requires lifelong supplementation, and decrease in bile salt reabsorption, causing fat malabsorption and diarrhea. Management includes a micronutrient plan giving B12, iron, calcium, vitamin D, fat-soluble vitamins, magnesium supplementation. For her diet, include small frequent meals, and monitoring the stool output. Follow-up would include weight and functional status, labs like CBC checking for the white blood cells, iron panel, vitamin B12, and also her bone density monitoring. We also want to monitor her electrolytes, renal function, and weight trends. So for the PES statement, so what we saw in this patient was she had a severe protein caloric malnutrition. Inadequate intake of protein calories resulted in significant weight loss and nutritional depletion evident by the low BMI, weight loss, and albumin of 1.8. Due to the malabsorption, increased metabolic demand, and inadequate intake. Due to the extensive small bowel resections, peritoneal ileum resection, active infection inflammation, and critical illness requiring increased metabolic support. And it was evident in her labs, which included BMI of 17.4, which is classified as underweight, 12% weight loss, so 16 pounds weight loss, and a resection of 122 centimeter of bowel. Now, complications and nutritional implications. So the loss of duodenum. Duodenum plays a critical role in iron absorption, calcium absorption. So initial digestion via the pancreatic enzyme bile removal leads to increased risk of iron deficiency anemia, which is supported in her labs by low hemoglobin. We also have increased calcium absorption, which causes a risk of osteopenia, osteoporosis. We also have reduced mixing of chyme with the digestive enzyme, which impairs micronutrient digestion. The resection of proximal jejunum. Jejunum is the primary site for carbohydrate, protein, and lipid absorption, as well as water-soluble vitamin absorption. So resection in that area results in global micronutrient malabsorption, increased risk of energy protein malnutrition, as well as diarrhea due to osmotic imbalances. Resection in the terminal ileum, so that's essential for vitamin B12 absorption, bile acid absorption. Resection includes a lifelong vitamin B12 deficiency requiring supplementation, as well as bile acid malabsorption, leading to diarrhea. So fat malabsorption leads to deficiencies in the fat soluble vitamins as well. So complications, short bowel syndrome. So because of the combined resections results in short bowel syndrome. It's characterized by reduced absorptive surface area, chronic diarrhea and dehydration, and electrolyte imbalances, long-term dependence on specialized nutrition therapy. So, dietary strategy. Small frequent meals. Eat 5 to 6 small meals daily to reduce the GI burden and improve nutrition absorption. High protein vegan sources like lentils, tofu, tam, quinoa, nuts, and seeds. Moderate fat intake, so monitor the tolerance. Consider the MCT oil if fat malabsorption. And foods to avoid would be the high oxalate foods, high sugar beverages, and lifelong supplementation of the vitamin B12, vitamin D 10,000 to 2,000, 1,000 to 2,000 daily, calcium 1200 milligram daily, and fat soluble vitamins, as well as hydration management, so oral rehydration solutions. Many medications were given regarding her admission and her symptoms. So ivermectin was given to treat the parasitic infection they called the Ischoriasis. Omeprazole, famotidine reduced the gastric acid that impaired the B12 and mineral absorption. And cholestyramine was given that binds the bile acids. and it was for bile acid diarrhea. Loperam- Loperamide to reduce the diarrhea, improve nutrient absorption, as well as the vitamin D to 50,000 IU weekly to increase her vitamin D level, as well as magnesium oxide that corrects her deficiency. So for her long-term monitoring includes regular labs and bone density screening and weight monitoring. So we saw this clinical case summary. She had a severe malnutrition that resulted from infection, surgical resection, pre-existing Crohn's disease. We saw her come in with BMI of 17.4, which was a 12% weight loss from her normal weight and a 16-pound weight loss. Low levels of albumin, including infection and inflammation. We started her on an early enteral nutrition, so critical post-op intervention to prevent complication. PEG replacement with the vital 1.5 was given within 48 hours of surgery and provided long-term care, so focus on micronutrient replacement and short bowel syndrome management. So to sum it up, Elsie is a 32-year-old female who presented with a 3-month history of progressive GI symptoms, including abdominal distension, poor appetite, nausea, epigastric pain, and significant unintentional weight loss. Her condition acutely worsened several days prior to admission with the development of fever, diarrhea, cough, rash, generalized malaise, promoting transfer to the ICU. Upon admission, her clinical status rapidly deteriorated, and she developed hypotension and pulmonary edema, requiring intubation and mechanical ventilation in the ICU. A nasogastric tube was placed for gastric decompression, and a central venous line was inserted to initiate total parenteral nutrition therapy (TPN) due to her inability to tolerate the oral intake. Labs were done, imagings were done. So imaging included the abdomen, X-rays, ultrasound, CT scan, which revealed markedly dilated loops of small bowel with non-peristalsis and multiple curvilinear tubular structures consisting with parasitic infestation. A mass was also noted that caused mechanical obstruction in the distal duodenum, raising concern for small bowel obstruction secondary to scoriasis with associated bowel ischemia. Based on these findings, Elsie was taken to the operating room for exploratory laparotomy. Intraoperatively, there was found extensive bowel necrosis requiring the section of approximately 100 centimeters of proximal jejunum and complete removal of the duodenum. A large bezoar-like mass of Ascaris worms was also identified and removed, and end-to-end anastomosis was performed. Post-op, Elsie remained critically ill but gradually stabilized. By post-op day 4, bowel function returned, allowing for discontinuation of TPN and removal of the nasogastric tube. A percutaneous endoscopic gastrostomy PEG tube was placed to initiate enteral nutrition. During her hospital course, she received multiple medications, including ivermectin for parasitic infection and antifungal therapy for her rash, which resolved. However, she developed complications including DIC, which is a disseminated intravascular coagulation evident by the petechiae, purpura, and hematuria, and was treated with heparin. She also developed a stage 3 pressure injury requiring nutritional and wound care support. As her conditions improved, Elsie was weaned off the mechanical ventilation and transitioned to oral intake. After evaluation by the speech-language pathology that confirmed safe swallowing, her PEG tube was subsequently removed. Nutritional rehabilitation focused on addressing her severe malnutrition and supporting recovery following extensive bowel resection. Given the significant loss of absorptive surface area and a prior surgical history, she is at risk for short bowel syndrome and long-term nutritional deficiencies. At discharge, after approximately 1 month of hospitalization, Elsie had shown clinical improvement, including weight gain and increased strength. However, due to the extent of the bowel loss and ongoing risk of intestinal failure, she was scheduled for evaluation and potential bowel transplantation at a specialized center. So this was a case of severe malabsorption due to multiple resections and the nutritional implications and the management. Thank you for watching.